Dr. Ghoshal has explicitly told you what are the requirements in adults. So when we have children, the first thing we have to look at is a clinical head-to-toe examination, signs of vitamin deficiencies, and various kinds of growth issues that take place from top to bottom. You can see you have to examine for bite out spots, rickets, and things like that. Then you have to look at the weight and the height and the Z-scores and the linear growth, the body mass index and the Z-scores, mid-arm circumference, waist hip circumferences, triceps skin fold thicknesses. And these are some parameters that we use to assess nutrition in a patient. Now then you have biochemical parameters also, such as albumin, calcium, vitamin D, the bone density. And nowadays, for research purposes, people have started looking at the psoas muscle thickness for sarcopenias. And there are numerous other parameters that we can go on and on, but that will not be the part of this lecture. So if you look at children with liver diseases, on one hand, you have you encourage dietary intake for patients who have cirrhosis, malnutrition, and emaciation. On the other hand, you restrict dietary intake with patients with non-alcoholic fatty liver disease and obesity. So there is a big paradigm. Things like acute viral hepatitis, where the patients usually, they have dietary taboos. Don't have spices, don't have oils, don't have this, don't have that. And these are families who deliberately restrict. Vis-a-vis metabolic liver diseases, where the nature deliberately restricts. For example, patients with urea cycle defects don't like taking protein much. Patient with hereditary fructose intolerance, they don't like taking anything that contains sugar which produces fructose. So this is nature's way of restricting the diet to prevent the disease. When you have nutritional requirements in cirrhosis, number one is hypoalbuminemia. That is contributed by the sarcopenia. It is caused by poor protein mass, muscle mass. It can present in the form of edema, ascites, presents with hypocalcemia, bone loss. And the therapy of that is a high protein diet, albumin and calcium. Then you have bile salts and fatty acid deficiencies, where you can have weight loss, skin issues, coagulopathy, night blindness, and oral ulcers. And in such a scenario, because there are deficient bile salts and bile salts are required for long chain fatty acid absorption, we try and bypass this phenomenon by giving medium chain triglycerides and supplement with fat soluble vitamins and water soluble vitamins. For patients, these patients also require higher energy consumption, and hence they have fatigue and poor growth, and hence a carbohydrate-rich diet is prescribed. What are the additional problems in cirrhotics? Portal hypertension causes blood loss, which are overt and occult. So you need to give them iron and folic acid. Renal insufficiency, those patients who have in cirrhotics have oliguria and ascites reaccumulation. And in those patients, you have to give fluid restriction and sodium restriction. You can have hepatic encephalopathy. The patient is in altered sensorium. And in such patients, you have to give protein modification or branching amino acids. So if you look at the American Association for the Study of Liver, AASLD recommendations in 2014, they have said that in patient who's coming in hepatic encephalopathy, you don't have to do much except for transient reduction of the protein.
You have a talk today, you and Dr. Rahul both after 4 o'clock, right? Yeah. Dr. Moinak is right now.
So you have to give them a transient reduction of protein, and so that the patient doesn't go into an overt hepatic, when he's in overt hepatic encephalopathy. And thereafter, when he comes out of this hepatic encephalopathy, then you don't need to give prolonged restriction of the protein. That's no longer recommended. And you have to give them at least 1 to 1.5 grams per kg per day of protein. What is the choice of protein in such a scenario? You have to give either a vegetable-based or a dairy-based protein. Why? Because these contain high ornithine and arginine, which facilitate ammonia disposal, and they're low in the sulfated amino acids. And you know that the sulfated amino acids are the ones that cause mercaptan, hippuric acid, that cause further encephalopathy. So how to give, and at the same time, you have to restrict the animal meat in such patients because they contain high sulfated amino acids, and these are the precursors of the mercaptans in the indolence. Along with that, you have to give a high fiber diet. It enhances the ammonia excretion, increases the intestinal transit, reduces the pH in the colon, and allows favorable microbiota to come. You must also remember that the short chain fatty acids that are derived from high fiber also contain 3 to 6 kilocalories per gram of energy. And this is a very important source of energy for these patients. Now, branch chain amino acids in chronic liver disease, the concept is that branch chain amino acids are usually given because they have leucine, isoleucine, and valine. And vis-a-vis aromatic amino acids, which are less given because they contain phenylalanine, tyrosine, and tryptophan. So the branch chain amino acids generate lesser ammonia than the aromatic amino acid. And these aromatic amino acids actually cause false neurotransmitters such as serotonin to circulate into the brain, cross the blood-brain barrier, and cause more of hepatic encephalopathy. So oral branch chain amino acids is also one of the therapies in hepatic encephalopathy, but that is when there is a refractory. That means the first line drugs have not worked, the second line drugs have not worked, and in refractory cases, they give branch chain amino acids 0.25 to 0.5 grams per kg per day in children. When you see the ASLD recommendations for ascites, you will be seeing that in ascites, what they say is that you should restrict as much of oral salt as possible. Remember, 1 gram of table salt contains about 17 milliequivalents of sodium. And the restriction of sodium in such patients with ascites should be approximately 1 to 2 milliequivalents per day in infants and 1 to 2 grams per day in adolescents. So some of the items that contain high sodium are table salt, sauce, breads, all bakery products, packeted products, ice creams, even milk to a certain extent contains salt, but not too much. And the items that do not contain too much of salt are your regularly available items such as egg, fish, all the meats, and all the fruits and vegetables that we usually get. So in metabolic conditions, there are 3-4 areas that we have to look at. Either you can target the ingestion, that means things like galactosemia and fructose intolerance. These are 2 diseases which direct ingestion of the containing problems. So for example, galactosemia is a problem with the galactose. So you give a lactose-free diet. Fructose intolerance, as the name suggests, is a problem with the fructose. So you give a fructose-free diet. Or you can target the end product. For example, in glycogen storage disease, there is so much of glycogen which is being stored inside the liver that this glycogen does not come out and give glucose. So you target the end product by giving a certain item which can give rise to more of glucose, so such as cornstarch. Or you can target the toxic products, like for example, tyrosinemia, which is a problem with the tyrosine pathway. Here you give tyrosine and phenylalanine restriction. For supportive to the additional to this drug intervention, for all these cases, you must in cholestasis give medium chain triglycerides. In Wilson's disease, there's some role of restricting the copper in the diet. In ascites, you have to restrict the salt. And in hepatic encephalopathy, you must give branch chain amino acids. So these are some specific liver conditions where dietary interventions are possible in India. For example, urea cycle defects, you stop the protein. You restrict the protein. You can't stop, but you have to restrict. In citrulline deficiency, they have a tendency to restrict the carbohydrate, but enrich the protein because of a complex pathway, which I'm not going to go into. In fatty acid oxidation defects, they restrict the medium chain. It's a medium chain disease. So they give a different kind of a diet. And there are, of course, galactosemia, HFI, glycogen storage disease, and Wilson's disease. So what is it about Wilson's disease we need to know? You have to understand in India that the copper in the diet is not too much. In the West, where they consume a lot of meat products, in that liver, shellfish contain a lot of copper, nuts, chocolates, and mushrooms also contain copper. But in India, this is not our usual diet. Hence, these things do not burden our diet with copper. So in India, copper in the diet is little unless there is a drinking water supply which is having copper pipes in it. And in that also the recommendation is that the water supply should contain less than 0.1 parts per million of copper. So the dietary items in India that actually contain high copper food item by the the National Institute of Nutrition, you will see is red gram, soya bean, and some nuts, some spices. But you don't eat a lot of nuts and spices in large quantities. So that does not really give rise to a large burden of copper. The rest of the items in India contain low copper, less than 1 milligram per 100 grams of edible portion. Galactosemia in infants is a tricky issue. And in this, you have to give lactose-free formulation because lactose contains uh, glucose plus galactose, and this galactose is the one that is going to give rise to problem. So what are the options we have? You can give them a hydrolyzed formula, which does not contain any galactose at all. You can give them a non-lactose soy-based formula, but always remember, soy contains some amount of galactose, and that is really not recommended less than 6 months of age. And those that contain casein-based formula are not to be given at all, because casein contains galactose, and this galactose can affect the child. So is there any role of galactose restricted diet in children and adults in galactosemia? You can always argue and say that fruits and vegetables contain so much of galactose, why give them at all? So there are studies that have shown that the amount of galactose that is there in fruits and vegetables is hardly 50 milligrams per day to consume. Vis-a-vis the endogenous galactose, which is approximately 1000 milligrams is being produced in a daily basis. And this galactose in fruits and vegetables is usually bound into some other forms, and its significance is not very well known. And it's the free galactose that is more important for damage to the body. Hence, in galactosemia, we do not restrict fruits and vegetables. So this was a study which was done many years back, and they took a handful of patients and then they started giving them escalating doses of galactose in their diet, 200, 400, 600. And they measured the galactose 1 phosphatase levels and the urine galactitol levels, and they found that there is no difference even if you consume too much of galactose in your diet, especially in the form of fruits and vegetables. So they said that to develop a toxicity of the level of 600 milligrams of galactose, you need to consume 7 kilos of apples, 2.5 kilos of tomato, and 12 kgs of peas to reach this amount of galactose. And hence, we should not be actually, and which is not possible, obviously, and hence we should not be restricting fruits and vegetables. This I'll skip. Glycogen storage diseases are of many types. There is type 1, 2, 3, 4, 5, 6, up to 11. But the ones that cause liver disease are 1, 3, 6, 9, and 11. In one, the final step pathway is affected, and hence the problem is that no glucose is actually getting into the system, and that causes profound hypoglycemia. Whereas type 3, you will understand, is one step little above, and hence it causes less of hypoglycemia. So how do we treat? We treat with cornstarch therapy. Cornstarch therapy is basically, corn is a very good important of starch, and starch contains a very complex kind of sugar, which is in the form of alpha-1,4 and alpha-1,6 bonds, which is in 20:1 ratio. And these bonds are very difficult to break. So it has a sustained release of glucose in the intestine. Little by little, it is broken down, and hence it is a continuous supply of glucose into the body. So the alpha-1,4 linkages are broken by the salivary and the pancreatic amylases, but the Six bonds are usually broken by the brush border enzymes in the intestine. So what happens with the complex starch is that it slowly causes digestion and sustained glucose release. And how to give this constant therapies, it should be indigenously available in the sense that not the powdered regular formula that we have, but you take the kernels and you crush it in the uh, available chakki that you have, and you uncook this uncooked cornstarch, which is dissolved in cold water. This is what is fed. You can feed through a nasogastric tube or infusion pump only in the nighttime or only in the daytime and also the nighttime. Or you can give an intermittent 4 to 6 hour oral feeding, especially at night and early morning. And the dose is about 1.5 to 2.5 grams per kg per dose. The other dietary modifications that we need to do in GSD1 and 3. GSD1, we have to restrict the sucrose, and in cornstarch, and in that you don't need to do anything else. But in GSD3, there is no restriction required for sugar or milk. And here, because there is also a muscle breakdown that goes on, you must encourage protein intake approximately 3 grams per kg. So as it is common sense in hereditary fructose intolerance, you will not want to give anything that contains table sugar, fruits and juices, because all that contains fructose in it, and hence you will not be able to give. So you bank on sugar source, which is the pure glucose powder, and the rest of the items. What about the luminal diseases? How does that happen? So again, in luminal disorders, either you can target the ingestion. So for example, in celiac disease, you want to give a gluten-free diet. In all kinds of allergies, you want to give an elimination diet. FODMAPs in irritable bowel syndrome, as Dr. Ghoshal has just shown you. Medium chain triglycerides in intestinal appendicitis. Or you can target the end result. That means you give a diet in such a way that this diet affects the disease course. For example, in Crohn's disease, you give exclusive enteral nutrition. Right? And you, for supportive, for additional to drug intervention, are things like gastroesophageal reflux disease, eosinophilic esophagitis, and functional constipation, where some amount of diet plays a role. So what are the specific luminal disorders where dietary interventions are done in India? So gastroesophageal reflux disease, eosinophilic esophagitis, celiac disease, lymphangiectasia, Crohn's disease, functional constipation where you require a high fiber diet, irritable bowel syndrome, and then you have multiple food allergies and bovine milk allergies, and all this span over from neonate to childhood. So in gastroesophageal reflux disease, what is the dietary recommendation? Always remember, for infants, you thicken the feeds, because thickening means because of gravity, it tends to settle down in the stomach and less of it goes up to the gastroesophageal junction. So that has been shown to help the patients, and usually you thicken by a rice-based cereal. You give small frequent feeds because large volumes, it will tend to aspirate or go through the have more of reflux through the G junction, and the patient can have aspiration. And in refractory cases, you have to try hydrolyzed formula, especially those patients where a concomitant cow's milk allergy is suspected. And here you have to give a 2 to 4 weekly trial of this formula. In older children, once again, you reduce the meal size and you reduce something that will delay the gastric emptying, such as fats and chocolates, and you avoid things that will increase the pH of the gastric contents, such as citrus drinks, spicy foods, tomato, coffee, and cola drinks. In celiac disease, you have to understand that celiac disease is because of a wheat allergy, and it's not just wheat. There is allergy to wheat, rye, and barley. Rye is not consumed in India, but barley, they make malt and beer out of barley. So that is also to be restricted in celiac disease. There's a growing celiac belt in India. Initially, it was in the northern states only, and now it has slowly started because of population mixing. You can find it in southern parts of India and also in the northeastern parts of India. So it is a pan-Indian disease. What do you do in celiac disease? You give a lifelong gluten-free diet. That means you stop the wheat, you stop the barley, and you give a diet chart that does not contain any of these items. Supportive therapy is with hematinics, multivitamin, calcium, but that's only given for 3 months, after which the patient, once the diet has been implemented, he starts maintaining a good nutrition. So when you restrict the dietary therapy, you will see that there is a sudden improvement of all parameters: generalized well-being, symptom resolution, weight gain, height gain, pubertal spurts, and long-term complications can be avoided. And it's very, very important to elicit compliance and follow. And when you're not happy with the child's clinical response, you should always take the child in isolation and ask child-centric questions. So you ask leading questions. Do you share tiffin in school? If he says yes, that means the compliance is being breached. Does your friend make tasty parathas? That means if you're asking this question directly, that means to say, are you consuming something that is containing gluten in it? How many chocolates did your uncle give you last week? So you ask a question in such a way that it traps the child, and the child gives out the real reason as to why compliance is being breached. So sometimes you have to do these tactics and follow up to evaluate really the compliance in these patients. And thereafter, you have to give the feedback to the parents as to where the compliance is being breached. The common mistakes and their solutions, which we often do, is that we advise them to have paneer, but they buy the market paneer. And the market paneer that you buy, you would realize it's nice and thick like a cake. So that actually contains flour or suji in it. So you should actually make homemade engineered paneer. Juices are not allowed because the thickening agent in that is gluten. Tin products and preservatives also contain gluten. Toffees contain gluten, hence you should ask them to take clear candies. And most of the time they will say that we grind our rice in the nearby chakki, which is the grinder. But you have to understand that the chakki that they grind in the villages have also just ground the wheat in it, and hence the wheat particles will be mixed with the rice particles and other things, and hence that will be contaminated. Hence, you ask them to buy a dedicated grinder at home and do the grinding of the rice and other products in that. So the compliance is highest. You have issues during puberty or when the patient is been sent to a hospital or a mess. That time there is an issue. Persistent diarrhea, there are dietary therapies that are available, and dietary therapy is a cornerstone of management. Initially, you start with a low lactose diet. When that fails, you give a lactose-free diet, and then you may use a green banana diet, you may use a hydrolyzed diet, and finally, when everything fails, you go for total parenteral nutrition. There used to be a concept of giving diet C, which is a monosaccharide-based diet, but that is no longer practiced in today's times. What is a green banana formulation? So normally you and I eat the ripe banana, which is yellow in color, but the green banana is not ripe. That green banana is used in therapeutic purposes because it contains an amylase resistant starch, and which is not digested in the intestine. It is delivered directly into the colon, and the colonic bacteria will break it down to short chain fatty acids. And as I have told you, short chain fatty acids give some energy, that is 3 to 6 kilocalories per kg, and it has a trophic effect, and it increases in water and salt absorption. How to cook the green banana is that you take 2 green bananas, put it in a pressure cooker, take the pulp out, add some rice, some water into it, and some glucose into it, and you make it sort of a slurry, sort of a porridge, and you feed the patient, and he gets about 54 calories per 100 ml. Lactose intolerance is very important. With diarrhea, there comes a phase where lactose is intolerant. Lactose usually contains glucose and galactose, and it is broken down by the lactase. But in diarrhea, what happens is the tops of the villi are denuded, which contain the lactase. So the lactose comes directly into the colon, becomes unabsorbed, and that, when it is broken down by the colonic bacteria into hydrogen lactic acid, causes acidic or osmotic stools. In lactose intolerance, usually patients have perineal edema, and there is minimal lesion on the scrotum. And here you have to change over to soy feeds or low lactose feeds, continue the breast feeds, and introduce complementary feeds. In IBD, there are also nutritional issues, and these lead to protein energy malnutrition. And there are multiple reasons for the same. There is a concept of giving an exclusive enteral nutrition in Crohn's disease. This is used as a first-line therapy in West. And here the patient achieves remission for about 6 to 8 weeks. And this usually spares the child of steroids. And there are various postulations as to how exclusive enteral nutrition works in Crohn's disease. So the type of feed that are recommended, polymeric versus semi-elementary versus elementary formulations. There are no difference in the efficacy, and it is given usually for 2 to 12 weeks. Cow's milk protein allergy is a problem with infants and toddlers. Well, milk causes allergy, and this allergy causes colitis to occur. In these conditions, you have to stop all kinds of animal milk. So whether you're using cows or buffaloes or goats, they're one and the same. They all contain the similar antigen. You just have to stop the animal milk, and you have to change over to formula feed, give some calcium supplements, and for more than 6 months, those patients for more than 6 months, you encourage solid foods to eat. This practice has to be there you have to stop the bovine milk for about 1 to 2 years for the action to take place. Special dietary formulations are available. So basically you have a standard cow's milk protein formula. You break it down, you make it partially hydrolyzed formula, and then you have the extensively hydrolyzed formula and the amino acid formulas, which is containing even smaller particles. And these are to reduce the allergenicity in the diet. So there are some conditions where you would like to use an extensively hydrolyzed formula, and this is used in those patients who have cow's milk allergy for less than 6 months. It is the first choice of therapy. Those patients who are not responding to extensively hydrolyzed, they will change over to amino acid-based formula, and these are required in only 10% of individuals. Should we give soy formulation? Well, you should understand that infants have 20% cross-sensitivity to soy allergen when they already have a bovine milk allergy. And so it is not recommended less than 6 months of age, and soy per se can give rise to thyroid disorders, aluminum toxicity, and a lot of phytoestrogens, which can cause gonadal changes. How long we should restrict the milk and milk products? For the IG-mediated patients, those who do not have anaphylaxis, there the restrictions up to 12 months. But those who have colitis with anaphylaxis, that means it is an IgE-mediated reaction, it is going to be 18 months. In functional constipation, you would like to give a high fiber diet, and these are some items which contain high fiber. And you decrease the whole milk intake because these children are usually milk dependent, and as much if they consume a lot of milk, they won't eat anything else. So you reduce the milk. Medium chain triglycerides is very important, as I have told you. That's an important part of our management of cholestasis. Medium chain triglycerides are directly absorbed into the portal system. They give about 8.3 calories when they are broken down. And these are important in conditions such as intestinal lymphangiectasia, A beta lipoproteinemia, short bowel syndrome, cholestasis, and also in TPN and preterm low birth weight care. Thank you.